Local productions seen on Delta College Public Media are made possible with support from viewers like you. Thank you.
Hello, everyone. Welcome to Junia Doan's Spark. I'm Junia Doan, and thank you for joining us. My guest today is Dr. DeMann. Dr. DeMann is the managing director of Manhattan Medicine in New York and specializes in non-surgical orthopedics, regenerative injections, and sports injury management. Welcome, Dr. DeMann. What is pain physiologically?
Well, pain is a sensory perception of discomfort. It's actually quite of an interesting thing. And we feel sensation to our skin when we touch things, right? We feel light touch, we feel heat, we feel vibration, but pain is actually something different. Pain is not those sensations I just mentioned. It's actually a perception of discomfort, and it's processed in a part of the brain that also processes emotion. So pain has a crossover to emotion, and the way it's interpreted in the brain. It's designed to protect us, right? It's designed to create a very dramatic experience with something that's caustic or potentially dangerous, and so it elicits a very substantial response, sometimes in excess of what's necessary. But it keeps you alive. It keeps you from burning yourself, from hurting yourself, from doing all sorts of things that you would probably not be able to accomplish if you couldn't perceive pain. So,
Is it a two-way exchange between the physical and the emotional? So if you're emotionally upset, can you manifest physical pain?
so there's a lot of debate on what if you could manifest pain without any sort of mechanical or chemical stimuli, meaning that can you make it up in your head and not have anything outside your brain that actually is really causing the pain? And the answer is probably yes, but for the most part, the way it normally works is that you'll come in contact with something or something will hurt you in some way, and your body will interpret that in some way. So, because that's where the emotional aspect comes into play, some people will catastrophize pain and get extraordinarily uh, affected by it, and some people can actually tolerate it very well and go upon their normal day. They may be feeling the same things mechanically or physically as far as the nervous system is concerned, but the way they interpret that sensation is really what makes up the whole package of pain. So yes, there are some patients who can manifest the feeling of pain without any real noxious stimuli. Nothing has really hurt them, but yet they're in pain. Thankfully, that's very rare. More often than not, people will experience some stimuli and then either take that perception of discomfort and expand on it or contract it. So that's really what most people will do.
And I do want to say to the audience, Dr. DeMann has treated me in New York when I'm there uh, for a chronic neck issue. So I can attest to his skills, at least for me. But I'm always conscious that when people have pain, they're asked 1 to 10. Can is it sharp? Is it soft? Is it throb? That must give you some information about location or injury.
In medicine, we use various different tools because we can't get inside your head. We don't know what you're feeling, right? So we have to do certain things to kind of get a representation of what you're experiencing. Number one, we ask you, where is it? And very often you can point, which is very helpful, right? So that's the starting point. My shoulder hurts, or my knee hurts, or my back hurts. The second thing we want to know is how intense is this, and that's where those numerical scales come into play. Now they're not absolute. Your 7 is your 7. Somebody else's 10 is their 10. So there's no relationship between different individuals, but it gives me a rough idea of how it's affecting you. If somebody comes in and says, listen, and I say to them on a scale of 0 to 10, 10 being the worst pain you can imagine, what is this? And they say, oh my God, it's a 9. That immediately tells me that it's a pretty important sensation to them. The next thing is, what does it feel like to you? Like, again, I can't get inside your head. I don't know what it feels like. Does it feel sharp? Is it dull? Is it deep? Is it superficial? Is it burning? Is it achy? Each one of those different types of pain is a clue. It's a clue to where it's coming from and what might be causing it. So when you're doing an interview with a patient, you're asking questions, and to the patient it seems fairly routine. From the clinician, it's a series of sort of checkpoints, and you're making little deviations in the conversation based on the answers until you arrive at an endpoint. As you get older and more experienced in practice, that process goes faster and faster and faster, and you get more intuitive. But you still need that information because, again, you cannot feel what the patient's feeling. Just the same way I can say to you, I can't taste what you're tasting. If you taste an orange, your idea of what an orange tastes like, I have no idea if it's what I taste. So that's very similar to pain.
So do you diagnose yourself if you have pain or when you have pain?
It's very hard. I was telling you off camera before we started that I injured my neck a few weeks ago, and I experienced what my patients experience, pain. And doctors should not be their own doctors, right? So because you can chat yourself into a direction where an objective observer can be much better at evaluating you. But again, I am able to figure out with my own issue faster than I could figure out with a patient because I can get that information quicker. Pain has been something that I've been incredibly interested in my whole career because it's counterintuitive, but when patients are in pain and they're in pain for a while, the brain says, oh, you know what? This stimulus is really important because it's been there for a long time. Let's make it more efficient. Let's reinforce the pathways that you feel that pain through. Let's expand the part of the brain that processes that pain. And in an unfortunate turn of events, you actually wind up making the pain a bigger part of your life. It sometimes expands the pain, makes it harder to get rid of. Not because you don't want to get rid of it, it's because that's how we're wired. We're wired neurologically to reinforce pathways that we see a lot or we perceive as important. And for survival, nothing is more important than pain. You will do anything to get out of pain. So your brain says this, okay, it's very important. So you asked me another question off camera. I said, when is pain chronic? Well, there's a medical definition of chronic pain, and that is pain that exists past 6 months. But it's not that clear cut. But somewhere around 6 months, that facilitation, that adaptation of the brain and the neurology of our body starts to occur. So the longer you've been in pain, past 6 months, the harder it is to get rid of that pain because your body is almost setting itself up to focus more on that sensation, not less.
Very interesting. Can a patient or a pre-patient who hasn't quite come to you or somebody else, can they counter that by visualization or hypnosis or massage or something else?
I think the most important thing when you're treating pain is to do two things. Number one, try to figure out what the cause is as quickly as possible. Because the longer you expose somebody to pain, the more likely it is it can be difficult to get rid of their pain fully because of the mechanisms we talked about, how the brain is wired to make that pain more and more a focus of
Yep.
their attention. The second thing is that pain usually means something bad's happening, right? So we don't want tissue damage. If you have a pinched nerve, the nerve will deal with the pinching for a certain period of time. But if it's pinched for too long, the nerve will start to die and you can develop neurologic symptoms. If you are causing a tendon if a tendon is causing pain, if you don't treat it soon enough, sometimes a tendon can get damaged, tendons can rupture. So the cause of the pain is important to deal with. And also, we don't want pain to go too long because it gets harder and harder to rid your body of the pain the longer you've had it. Now, the tools that you mentioned, biofeedback, meditation, visualization, these are all excellent tools to help mitigate the effects of how pain is processed in your body, meaning how you respond to it. It's not going to get rid of the pain. That's important that you address where the pain's coming from, but it'll help you deal with the pain and function with it on a day-to-day basis.
Okay, so what are the next steps for a person for whom that is not working?
Well, this is where it gets tough because in the world of pain treatment, there are lots of different specialists, and it's also often very difficult for patients to know who to see. And they may randomly walk into the right office. For instance, if you've got back pain, you may not want to see the orthopedic surgeon who's doing spine surgeries all day long as the first person. You may not need that sort of type of care. You might be better off to see a physical therapist. Generally speaking, you want to start off by trying to find a practitioner who can discover what the source of your pain is. If it's musculoskeletal pain, pain through your knees, your backs, your shoulders, you have a couple of options. You can see a physiatrist, a physical medicine specialist. You can see your primary care doctor. Sometimes they are used to seeing some of these types of pains and know what to do or maybe where to send you.
So, Drew, you were describing what uh, a, a, a person could do at pain, how they would follow up professionally. Yes?
Yeah. Yeah, I mean, I
Okay.
can break it down into two parts that somebody who's in significant pain or pain for a while should focus on. Number one,
Yeah.
try to find
Okay.
somebody quickly as possible who can diagnose the source of the pain. Sometimes that's a little daunting because you don't know the right specialist. But generally speaking, if you see somebody who's non-surgical, you're probably better off because most patients don't require surgery as a first form of care. So a sports medicine doctor, a physical therapist, a pain management doctor, a chiropractor, somebody who deals with musculoskeletal pain on a daily basis who's non-surgical, or all of the above. And it's not, it's very often patients are better served by seeing multiple different specialists and sort of getting perspectives on what their problem is, especially if it's been a long-standing issue that's not been resolved by treatment as a first line of defense. The second thing that most patients should try to do is to start learning how to deal with the pain. In other words, things that you mentioned earlier in the discussion, meditation, biofeedback, visualization, these are all very healthy techniques in order to learn how to uh, compartmentalize the pain, but more importantly, how to uh, put it into a part of your life that doesn't overwhelm you. Very often I'll see patients in the office, and while two patients might have exactly the same type of pain, one patient might catastrophize the pain and make it a daily ritual of everything that encompasses their life is focused on their pain. The other person with exactly the same complaint is able to compartmentalize it, move on with their life, and be much more productive. And obviously, that second option is the better for most people.
What kinds of therapy do you offer or just able to offer following the ones you just mentioned?
Well, I'm often the person that patients go see when they have not gotten results by somebody else. So I usually start with a very thorough re-examination of where their pain might be coming from. Because in my experience, the most common reason why people fail treatment is because they were misdiagnosed. Uh, and generally speaking, what that means is that if you apply a therapy that we know works almost all the time, and patients have failed therapy after therapy after therapy, it's very likely that the diagnosis is more in question. So the thing that I do, which I think is a little unique, in that I spend more time re-examining the patient and trying to peel away the layers of where exactly is the root cause of this pain. One of the techniques I use is something called a diagnostic injection. It's a very simple technique. We take a small amount of lidocaine, almost like Novocaine you'd have at the dentist, and we put it on something that we think is the source of their pain, something that maybe showed up on their MRI or something that came up in an examination. And we do this in the office. And if we can put that lidocaine on a structure that it's supposed to be causing their pain, when they get off that table, within 5 minutes, they should have less pain. If they don't get off the table and have less pain right after that procedure, which is called a diagnostic injection, then whatever shows up on their MRI or what they've been told in the past is the source of the pain wasn't their pain. And now we have to move on. So, diagnostic injections is a tool that I use quite frequently to confirm the source of somebody or the root cause of somebody's pain. That's a very important first step, one that I think often gets missed. I had a patient who came to see me the other day, and they were told they had a very unusual diagnosis called coxum senilum. And they were pointing to their hip. and they were given a recommendation for surgery. And I spoke to the patient and I said to them, well, first of all, coxum senilum in Latin means old hip. That's not a diagnosis. So, number two, did the doctor examine you? Well, we had a conversation. Did the doctor touch you? No. So, no physical exam by touch. Red flag number two. Were there any imaging taken? Well, only an x ray. That's not adequate. There are so many things in that area that can cause pain that would not be addressed by a total hip replacement. It could be muscle, it could be tendon, it could be bursa, it could be referred pain. So we did a diagnostic injection. We took a small amount of lidocaine, put it in her hip joint, and got her off the table. And lo and behold, her hip pain was still there. What that meant was that if she had that total hip removed, she would have had the same pain after the surgery that she had before. So for me, diagnosis is everything.
Just from your own taking care of a person, are there certain protocols that are more long lasting or that need to be replicated periodically?
I see a lot of patients who have overuse injuries. And what that means is they're doing something on a repetitive basis too frequently or too aggressively for their body to adapt to it. That kind of patient, if they show up in your office and you fix whatever they have caused, but they go back to those exact same patterns of movement and habits of overuse, they're going to be back again. It's not that the treatment failed, is that they're reproducing the injury over and over again. So the answer to that question is absolutely. I'm probably going to see them again and again and again. So part of what I do is I try to say to them, listen, we now identify what your problem is. We know where it came from. It's a little insanity to go back exactly the same thing that got you here. So maybe we should do something different. Maybe you shouldn't play tennis every day for 2 hours. You play it every third day. Maybe in playing, instead of for 2 hours, you play for 1 hour, and the other days you go bicycling or swimming. Now let's go back to the other case where it's not an overuse syndrome. It's a one-off. It's a something that happened that probably will never happen again. I expect to fix that patient and never see them again, hopefully, for that condition. So very different answers depending on the patient.
For a person who had lived for more than 6 months and therefore established the pattern you mentioned earlier, how long does it take for the body to reorient?
It's a very smart question. In my experience, it can be up to the same amount of time that it took them to get to see you. Meaning that if somebody's had pain for 6 months, it can take you 4 to 6 months to really break that pattern. Now, we've got all these very sophisticated tools and techniques to shorten that period. So we're getting better and better. But with patients who will come in who have 5 year histories of chronic back pain, they have to adjust their expectations. They're not going to be 100% in 2 months or a month or a week. And anybody who tells them that is probably misleading them. Even the surgeon who wants to do their best and give them a quick fix, maybe in the form of a surgical procedure. Now, we have a spine surgeon in our practice, and we talk about this all the time. Even when you remove damaged tissue surgically, that pattern of pain has been there for a long time, and the body has to unlearn it. And I tell them sometimes it can take 1/3 to 1/2 of the time, even as much as the time that they took to get there, meaning that a 5 year history might take a year or 2 years to fully work its way out of the body.
What is the role of breathing in pain?
Yeah, so many things, right? So from a very simple perspective, it increases oxygen intake, right? Oxygen is the necessity of all types of healing. So when you breathe and you breathe fully and you breathe rhythmically, you get in normal amounts of oxygen, you keep your oxygen saturation levels higher, and it's better for you. Very often patients don't breathe properly, they shallow breathe. They're in pain, they don't really take a deep breath. They're in stress, they don't take a deep breath. So just learning how to breathe can be a big difference in just how much oxygen their body gets. Number two, the active breathing stimulates a certain part of your nervous system called the parasympathetic nervous system. If I have you take long, deep, relaxing breaths in and out, you will suppress your sympathetic nervous system, the fight or flight system, and you will stimulate your parasympathetic nervous system, the one that relaxes you and helps you accommodate to sort of stress. And that alone can change the chemistry in your body. So for instance, if I teach you how to do box breathing and meditative breathing, you can lower your cortisol levels. Cortisol, as it goes down, reduces inflammation in the body. As inflammation in the body goes down, pain goes down. So there are lots of sequential benefits to simple things like learning how to breathe.
Does box breathing change the amount you do depending on uh, the severity, but the type of problem you have, or is
Not
there a
really.
minimum?
I think all the breathing techniques, whether it's box breathing or uh, techniques of counting when you breathe in general, focus you on your breath. And when you focus on your breath, you then control your breathing and you stimulate that parasympathetic system. So for me, it's not that I don't think there are differences in techniques. I just think the overall principle, the how they all work is probably very close to the same. And that is having you focus on your breath, on relaxation, and trying to get yourself in a calmer state, which has a real chemical effect on your body. The net is that I'm not as rigid on what style of breathing you want to try, but if you just try some form of breath work, you can very often get a positive result.
What do you think about energy or grounding or some of these things that certain parts of the population prefer to do or want to do or are interested in?
In medicine, you have this false ego, and the ego is, well, if you don't understand it, it must not work. Well, that's ridiculous. There are many things out there that the public finds, and they find that they work by sheer brute force that we don't understand. Grounding is one of those things that does, I think, have a basis in science. There's ions in your body. Your body is basically a big battery. And when you ground, you basically allow ion exchange with the ground. Same way if something builds up static electricity, you can sort of let that static electricity leave the body when you touch something. So I think there's probably a lot of evidence to show that grounding probably has lots of benefits. I tell patients, as long as it doesn't hurt you, as long as it doesn't cost you an arm and leg and somebody's not charging you a ridiculous amount to try this new therapy that only they do, try things because everybody's chemistry is different and everybody's body is different. And we do not understand a lot of how our bodies work. We understand a little bit. And so if somebody feels good by grounding, if somebody feels good when they come out of the sauna, there's lots of evidence to show that heat exposure is very helpful. Cryotherapy, meditation, their sound therapy. I think that all these little types of treatments, when you combine them, they work even better. I would say if you're in chronic pain, go for it.
What drew you to the medical field and specifically why chiropractic?
And my father was originally a chiropractor. So was my brother and my uncle. So I started my career actually not in chiropractic. I started my career as an orthopedic researcher, thinking that I was going to study orthopedics and biomechanics my whole career. I got my graduate degree, and then I decided to become a chiropractor because I saw day to day these phenomenal results that my family and my father were having with his patients, and I saw the relationship that he had with his patients. It was a very different kind of healthcare relationship. And then I practiced chiropractic for a long time, and then decided that I wanted to sort of expand my scope of things that I could do. So I went back to school and studied pain management and orthopedics. And then I got my degree, and now I do primarily non-surgical orthopedics, including injections and operate more like if you remember the old time osteopaths where they had manual skills, but they also had medical skills. Day to day, I probably do more on the medical side, but I understand the value of the manual skills. So it's kind of been a long path for me. Kind of, I joke with my kids, I don't recommend doing what I did. It took 3 times as long as most careers take. But I also think it gave me an unusually wide perspective of different types of things. So
What's coming down in the future, the near future, that interests you that might accelerate healing?
one of the things I'm most excited about is this new field of regenerative medicine. I got exposed to regenerative medicine about 15 years ago with performing a stem cell procedure on a patient who had chronic, unrelenting back pain, and he was an opiate dependent patient. And I saw the quote unquote miracle of stem cells firsthand, meaning that how amazing our own body's regenerative capabilities are. And we are now 15 years later, and we're using stem cell therapies now to treat knee pain and back pain, hip pain, headaches every day. In our clinic, every week, we see something that I'm truly impressed by with the use of stem cells. And I think that's where orthopedics and pain is going to go in the future, harnessing our own body's ability to heal using our regenerative capabilities with things like stem cells and other techniques that we have now.
Is there a downside to using stem cells?
There's a downside to everything, but thankfully, when you're using your own body cells, not a donor cell, and you do it in a safe environment by a skilled practitioner, I think the downside is minimal to none. The things that I worry about are the same things I worry about in any procedure, like infection. But because we're moving cells from one location to the body to another, and these are your own cells doing their sort of own programmed genetic treatments, I think that risks are very, very small. In fact, when you look at the literature, I don't think there are any reports of any significant or severe complications from the use of stem cell therapy when it's done properly.
Thank you, Drew. Thank you. So, quick summary, everybody. Don't let your pain go to the 6 month point because your body changes somewhat. And be patient with the therapy if you've had long term pain. Lots of ways to approach it. No problem with doing things as long as you stay safe and careful. And your life will improve. You may have to edit what you do or add to what you do, but your life will be more full, and that's what we want. Please go out and do something kind for someone you know and someone you don't know, and do it every day going forward. And I'll be happy to see you next time. Have a great week, everybody.
To contact Junia, send her an email at juniadonsthespark@gmail.com. For more information, program schedules, and news about future guests, go to www.juniadonsthespark.com. Thank you for joining us. See you next time on Junia Doan's The Spark.
Local productions seen on Delta College Public Media are made possible with support from viewers like you. Thank you.